And I really appreciate this opportunity to talk to my friends and colleagues about what we're doing and the transitions that we're making in our practice based on this COVID-19 outbreak that has really overwhelmed us and changed our life so dramatically and drastically, both personally as well as professionally. And I would give a disclaimer that anything I say right now probably is going to change by tomorrow, as we see the pendulum keeps swinging and how we manage things. And I also like to congratulate and thank the American Academy of Ophthalmology for their leadership role in giving recommendations that implore safety, not only for us and our patients, but for really everybody involved with eye care and healthcare in general. So what have we done? I've been asked to talk about what have we done specifically. Well, I'll tell you, it's been draconian. And I know that for many of you that are practicing clinicians, as well as industry partners that are watching this, it's been draconian for all of us. From our research center, the ability to enroll patients has basically ceased, to our clinical practices. And I'll talk about that a little bit more in depth in a second, where we've slowed to a trickle. And finally, our ASC, which essentially is shut down right now. This has been a dramatic impact, both for patient care, both for us as doctors, as well as us as business people. And we look to better days ahead. In terms of my clinical practice, kind of the hands-on, what are we doing right now and what does that look like in my office? It looks ridiculously slow. We have enacted so many barriers to try to prevent us from becoming vectors of the disease to other people that it almost creates such an onerous impasse that seeing patients is almost infinitesimally slow. What do I mean by that? Let me give you an example. Let me granulate that. Patient calls to come in. They have what is considered an urgent or an essential visit in my glaucoma practice. I'm a glaucoma specialist, of course. Maybe it's somebody who feels pressure in their eye or their eye's red with the medicine that they've been on, or signs of a post-op infection. We screen them on the telephone. Have they had any overseas trips or any contact with a COVID-19 patient? Do they have a cough, et cetera? And each of your practices probably have their own SOP, your own standard operating procedure to manage that. They get screened again at the door. In addition, on that initial phone call, we're asking them if they have a mask to wear at home, because we don't want to remove the masks from our frontline providers at our hospitals. So we're limited on masks. We wear a mask. We're wearing an N95 mask to try to reduce viral particle shed. And then in between us, we've built screens. My office manager, Jennifer Blassingame, has developed a screen. So we call it the Blassingame block. And we've put them on all our slit lamps in the office. And I told her if they become successful commercially, she's gonna get the VIG on those. So we have 3 barriers between the patient and myself. And in addition, I've been swabbing my nares, both at the beginning of the day and at the end of the day, with betadine. There are some thoughts that might reduce virus particles in my nares. And we're having minimal conversation in the room with the patient. We're not talking at AAO recommendations at the slit lamp. And then we're following up with the patient with any extended conversation remotely. We're just about to enact a telemedicine platform at the practice. We're looking at a couple vendors. We're looking at Zoom, the platform that I'm on now, talking to you. And we're going to see which one works best. Trial by fire here on that one. And I know that many of my colleagues are looking at different platforms for telemedicine. And I actually think that's a good thing, because I think that we'll carry that forward. We'll learn from this, and we'll implement at least parts of our practice, telemedicine, for patients that live far away, for quick follow-up visits if a question regarding a medicine occurs. So we can all learn from this and make our practices better in the future and prepare for other inevitabilities down the line. So it's not all bad. It's 98% bad, but it's 2% okay. You got to learn, and that's what we're trying to do at our practice. And then finally, we're just trying to stay in touch with our patients through our websites, through communication with our patient advocates, our administrative team. We're just trying to keep a hands-on touch as best we can. But we're trying to extend our pharmacology refills with as big an allotment of drugs that we can get the patients in case this goes another quarter or two of shutdown. And so we want to make sure that patients have access to their medicines. And we're trying to look at alternative therapeutic treatments for those patients that need more than medicine. What does that look like? Well, we're employing things like laser treatment for patients that have glaucoma that's not under control, or maybe we would have done a surgical procedure before. Maybe we're using some type of transscleral procedure, so we don't have to do a surgical intervention. And even employing, as crazy it may sound, some older medicines that haven't been used in a while, like pilocarpine or oral carbonic anhydrase inhibitors. So we're choosing off a narrow plate, but we're trying to do the best we can in a very tough environment. And most importantly, we're trying to stay positive and trying to speak to our colleagues and friends electronically and remotely. We're trying to work closely with our vendors, and we're trying to work very closely with our partners in industry. So I want to thank Helio for allowing me the platform to speak with everybody today. And I wish you all health and happiness, and health not only for you, but your family and patients. Be well, be well.